The true incidence of anorectal abscess fistula is not known because most reports come from a large colorectal surgery practice or a single institution. In addition, many cases of anorectal abscesses are drained in the office, outpatient clinics, surgery centers, or emergency department, and as such, no formal record, that is, operating room or hospital discharge data, is available. Now, this is a case of a simple anal fistula wherein we have injected hydrogen peroxide from the external opening which is emerging from the internal opening in the anal canal. Again, methylene blue dye is injected to confirm the course of the fistula tract, and this is followed by inserting a fistula probe to perform the fistulotomy or laying open of the fistula tract. Anorectal abscess is believed to originate from infected anal glands. The infection, originally an intersphincteric abscess, finds a path of least resistance to spray. If it extends caudad between the internal and external sphincter to reach the anal verge, it produces a perianal abscess. If it ruptures through the external sphincter to reach the istiorectal fossa, it is called istiorectal abscess. If the abscess extended in a cephalad direction between the layer of the rectal smooth muscle, it will produce a high intermuscular abscess which is on occasion is labeled as submucosal abscess. Rarely, infection may spread above the levator space producing a supralevator abscess. A deep postanal abscess may spread to one or both istiorectal fossae and result in a horseshoe abscess. So now we are laying open the fistula strap using a diode laser which splits almost in a bloodless fashion the entire fistula tract and the overlying skin and subcutaneous tissue. Aside from cryptoglandular origin, the other causes of anorectal suppuration may result from the downward spread of pelvic infection from appendicitis, diverticulitis, and gynecological sepsis resulting in supralevator abscess. This in turn may track caudad through the levators into the istiorectal space. Crohn's disease of mid and lower rectum as well as the anorectum by its transmural pathologic nature may extend to perirectal or perianal space as an abscess fistula. Similarly, ingested chicken and fish bones as well as swallowed toothpicks may puncture the wall of the rectum resulting in significant sepsis. External penetrating injuries like stab, gunshot, shotgun wounds may result in an overt injury, though at times more minor or subtle injury gradually proceeds to full-blown perirectal sepsis. Perforation of low rectal cancer may also present with large istiorectal abscesses. It is important to biopsy the abscess well in order not to miss the underlying cancer. Specific infections such as tuberculosis have been also held responsible for such occurrence. Fungal infections, especially actinomycosis and oxyuris vermicularis infestation, have been known to produce abscess fistula in adult and children. The clinical picture of anorectal abscess fistula depends on the level of the abscess. If an imaginary line is drawn across the anorectal ring, supralevator and high intermuscular abscesses are located above this level. This will often manifest with systemic symptoms. The intersphincteric, istiorectal and perianal abscesses are located caudate to the anorectal ring. They produce pain and swelling but are not associated with many systemic findings. So anorectal abscesses may drain spontaneously or may require surgical incision and drainage. When the abscess is drained, there are three possible outcomes. 1. The abscess may completely heal without recurrence. This signifies possible lack of communication with the anal canal. 2. The abscess may heal and recur at the same time, same site, weeks, months or even years later. This signifies presence of communication to the dentate line, that is a fistula. And the abscess does not heal but continues to drain. Occasionally a thin film of epithelium may cover the external opening causing collection of fluid. blood or pus underneath it. This may give the patient a false sense of recovery until the area swells, causes pain or ruptures, and fistula reappears. Anorectal fistulas are associated with pre-existing abscesses in the majority of cases. In a study of 100 recurrent anorectal abscesses, an underlying fistula was demonstrated in almost 68% of the patients.